Now what I want us to reflect on, just very briefly, are what I call the ethically relevant features of an aging population, of older persons. And we've talked a little bit about successful aging, compacted morbidity. The point that this makes, and again, the parliamentary secretary, she did a nice job in making this clear. The elderly are not a homogeneous group. They are as diverse as 40-year-olds or as Vancouverites. They are incredibly diverse. So one of the problems with ageism is when we begin to think that this is a mass and everything in the mass is exactly like everything else in the mass. Forget to understand this uniqueness, and in actual facts, these differences become very important. How well someone has aged, and again, it's due to a combination of basically genetics, some environmental factors, maybe luck or grace, depending on whether you're a religious person or not, in your family, in your social situation, and whether or not you got a good education and work. Those are the things that make for really health and wellness, right? Whether or not you have compacted morbidity or you begin to experience medical conditions earlier. Because the earlier you experience them as you age, the combination of aging and chronic illness creates more need. Frailty, very interesting work on the notion of frailty, which, as you know, I'm sure those of you who work it, frailty is a very particular notion. It's this population that actually do okay until they have a problem. And once they have a problem, the frailty and understanding the biological correlates of frailty, I know because I'm on a network of centers of excellence, is the object of some very interesting research. Please God, we get some research out of this that helps us with preventive activities for elderly. Chronic illness, multiple comorbidities, and then one of the biggest ethically relevant features is the rise of dementia in the elderly. Again, older population, as they get older, some of these diseases that occur more frequently in the elderly occur more frequently. In a society that privileges independence, choice, control, this is probably the thing more people fear than anything else. I could, in fact, go to a wheelchair, but the thought that I would not know my brothers devastates me. I mean, look at who I am. I'm a university professor. I understand myself in terms of my cognitive and interactional abilities. So this is a huge ethically significant issue. Moreover, as part of the diversity question, gender matters. So you saw women live longer, and I'm doing some stuff on long-term care ethics. More women are in long-term care and nursing facilities. I mean, actually move to a residential site than men, and they live longer. But older women have more long-term disability and chronic diseases than older men. Men, on the other hand, have more falls and accidents, and they experience social isolation way more than older women. It's your father or your grandfather who's living by himself, trying to cope in the old home. He's the one that, in fact, is less likely, unless you've got great family or friends, to have people come. The social isolation problem for men is different from women, but the care needs room. So when we begin to think of ethically relevant features, even gender matters. Now, this is a big one. There are enormously different approaches to independence and to decision-making among older persons. Okay, rule number one in ethics in healthcare or life: don't assume because you think this is a good thing that the person whom you're assisting thinks it's a good thing. Just because it's my worldview, it's my experience. If Nuala is this huge risk taker, I bungee jump. I'm learning to ice climb at 69. I mean, I am a wild woman. I've taken risks my whole life. I love risk taking. When I, in fact, are faced with decisions about dependence, medical technology, even perhaps dying, I assure you I'm going to be very different than Dr. Gallagher. Now, those of you who know Romaine, she is wimp of the north. You see how I'm changing it all up here, right? This doctor is afraid of her own shadow. She has schedules of her schedule. She gets to the corner when there's no traffic anywhere and it says stop, and Romaine stops. Totally risk adverse. Now, when Romaine, Dr. Gallagher, when she comes to decision making, do you understand what I'm trying to describe? To be respectful of her and her life values, she's going to be wimpy, and I'm going to be nuts. And the problems happen when I'm Romaine's doctor. No, it would happen the other way. She's going to be mine. She no baby. When wimpy is trying to treat risky and failing to understand this, then wimpy's saying, oh, no, I wouldn't have done it. It's not her job. Her job is to tell me the science, the medical possibility, the standards of care. I'm the one who says, hey, kiddo, you know me. I've gone for it my whole life. Let's go for broke. I'm ready to go to God if, in fact, I die. But I'd rather take the risk and see if my chances. So I'm being facetious to make a very important point. You understand what I'm saying. This means that when, in fact, older persons start making decisions, they're as different in the decision-making as they have been in their whole lives. Some have a strong need for control. Some demand, I got this from a very interesting article, the right to be dependent. The older persons, so we're going to do a panel at the end of the day, Romaine and I and Jared Clemens, on third-party decision-making. And there are seniors, just like there are 40-year-olds, less likely there, but seniors, who have the right to be dependent on their son, who will say, I don't want you to tell me, tell him. And we have to begin to understand that in a new way. Then, this point I want to make very, very clear, very, very clear. And think about this as you look at all of the sites of care and kinds of support issues for the elderly. There is a big difference between decisional competence and executional competence. As long as an older person has decisional competence, they express their values and what their choice is. The problem becomes when they know what their choices are, but they cannot execute them. Best example, darling, I want to stay in the house. Don't you ever put me in a nursing home. Don't you ever do that to me. I want to stay in the house. But you're the daughter going back and forth into this place that's becoming a rat trap, a hazard. Clearly she's in self-neglect, right? The situation now becomes she knows her own mind about what her values are and how she wants to live in her last years. But she cannot execute that without other people assisting her. Somebody's got to get her groceries. Somebody's got to make sure that the house is clean. This is where, when we begin to encounter some of the most difficult issues, particularly for seniors, that 90% that are living alone, and then the increasing number that require help, it's a continuum of help. Now we get into so who are we listening to? Because respecting the autonomy and the values of the person, the older person, are crucial. But the older person's not the only one to be considered. The consequences, whether it's family consequences or in institutions, staff is important. Then, just general observation. Because you're talking about aging in general, there are, and I'm experiencing this now in preparation for a different conference back in Nova Scotia, there are major differences between acute care, ethical decisions, and home and residential care for the aging. In the healthcare environment, there's a specific choice. You go back to the OR, you don't go back to the OR. You start another course of chemotherapy, you don't. It's in a controlled environment. The choices are specific. In long-term care and in home care, where we have supports for elderly persons with declining capacity and declining competence to take care of themselves, the decisions that are most important can be, when do I get up in the morning? Can I choose what I want to wear myself? Can I continue to eat potato chips even though eating potato chips gives me a choking fit? The issues become different issues. So, need to pay attention to that. And then this becomes crucially important as I come to the end of my comments, so we have a little time for conversation. This is probably, and you're going to see in my understanding for policy challenges, the most complex issue that we face. Older persons live with a wide range of support from friends and families. It's huge. It's from totally dependent, caring family, take turns, somebody's always making sure mom is okay, and do this in a way that's supportive, everybody's involved, to elder orphans. Elder orphans. And remember, this percentage that are living at home, the increasing numbers of them are home alone. They are home alone. And an elder orphan, and my understanding of the literature and my own experience in elder ethics, an elder orphan is an individual who all her family have died out, or they're so far away that they're of no help. And even her friends. So if she was a bowler, I mean, all her buds went from the Women's Bowling League. Or she belonged to a church group. And maybe there's one or two because her friends were her age. We have a huge set of issues here then that older persons live with this wide range of support. And some of them actually are neglected, profoundly neglected. This becomes important in terms of my second bullet. Families and what I call intimate others. And this is a language that I use preferentially because for many, many, many persons, including many, many elderly persons, it's not their family, even if they have a family. That's the persons who are most involved in their care support. It is intimate others. It is the fellow from the lodge who's been with this guy since they served together in World War II. Buds forever, right? It is the church group for this older woman for whom this has been incredibly important. So what you need to understand is we have to also begin to think of the balancing respect for independence and autonomy and decision-making promotion in the older person with acknowledging the fact that no one is an island, especially not if you're aging. That in fact, most persons want their family to be involved. Now, this becomes important. And when we talk about substitute decision-making at the end of the day, we'll go into this in some detail. Families and intimate others crucially support elders. I mean, unless they're these elder orphans. They do it for care. They do it for advocacy. It's the family members that come pounding on the door or making the appointment or going, right? It's someone speaks for, wait a minute, Mama can still stay, but she needs more than what you're giving her. So it's a care, it's an advocacy, and it's for assistance with decision-making. Even when the older person is still competent to make their decisions, most older persons who have loving friends and family around them test out the decision with those persons. That's different from having the son make the decision when his mother is still competent. That's what we'll talk about this afternoon. So what you need to understand is there's an ethically relevant set of questions that make even decision-making and the promotion of independence with the elderly substantially different. Substantially different. Interesting, one of the cases that we're going to be discussing at home in May is about persons who, in fact, are elderly who have always lived in high-risk situations. Bad neighborhoods, drunken spouse, lots of violence and abuse, criminal activity in the neighborhood. They have lived that way their whole life. And then someone from supportive care comes in and manages and assesses this, and all healthcare providers and all social assistance people that I know of immediately the safety and protection genes get warmed up and operative. And yet, and this happens big time in long-term care, you bring that person into a safe environment and you feel happy, and the person is uncomfortable as you know what. Because for them, their understanding of it, you and I are terrified to walk into the neighborhood, but they've lived there their whole life. So we have these very interesting conflicts about balancing respect for autonomy with the whole notion of our responsibility for care and protection. So I just said long-term care facilities and nursing homes have very, 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 very particular ethical issues. Not just about the meaning, the rite of passage in a move. Most of our rites of passage, you graduate from grammar school, you graduate from high school, maybe you go to college, you get your first job, you have your first date, maybe you marry, you get a promotion. The rites of passage are usually positive. The rite of passage in going from being independent to being in an institution has huge meaning. Huge meaning, and we've only begun. So there's meaning issues in decline and aging for everyone as we change function. but rite of passage. So there are huge, huge issues. The concept I want to leave you with here, because we don't have time to go into this, is in long-term care facilities, so nursing homes and institutional care, not only is there guilt that we have to put Mama now in, even when she said never do this, but at the other end of it, though we want to promote independence, patient-centered care, person-centered care, someone spoke to that, the fact is when you're in an institution, you're living with unchosen others. And the minute that you're living with unchosen others, it's not all about you. So part of the delicacy of an expanding area of ethics is the reflection on promoting autonomy and respect and privacy for individuals and institutions, but autonomy in community. So, finally, ethical challenges. Well, you can see, I think, that from some of my demographic, attitudinal, and then ethical issues, that I think that we've got huge issues in responding appropriately so that we can say we do respect our elders. That kind of fundamental notion, I don't know about your growing up, but I assure you the two things that, I'm the eldest and the only girl, I have two younger brothers, the two profound things that would be said to me again and again and again, you don't hurt anyone smaller than you, don't hit your brother. Nuala, don't hit your brother. You don't hurt somebody smaller than you. And the second thing I grew up with, no, that's Mrs. Harfield. You don't speak to her like that. For older persons, you have to show them respect. Respect your elders. I don't know what we say to kids anymore, what we say to each other anymore. Okay? But if we were, first, respect for both the dignity and diversity. This is not a homogeneous lump, and you know that well. The promotion of independence must be balanced with concerns for safety. And that is no small matter, either in the home, or when they're in community facilities, or when they're in residential facilities. Third, we must really find new ways to support meaningful autonomy, recognizing limits. In other words, people express their desires that have that decisional capacity, but they can't execute. They need others to help execute. Biggest issue for me, as I've come to look at this in detail over the last few years, we have to have real options for care. We really have to look at this issue. We're still so incredibly focused on the hospital and healthcare and the machinery. That's health. That's healthcare. That in fact this long-term combination of residential rehabilitation, hospice, palliative, that continuum is grossly underfunded, grossly undersupported by the average Canadian. They want the second heart transplant. But when you say, how can we in fact expand to meet this incredible rising population of need that doesn't need the big machines, they need a different way of coordinated care across needs and a combination of health care and residential care. Then, look at this point here. We have a huge challenge. All of you know this, but I need to name the importance of acknowledging the consequences for others of trying to respect our elders. Doing good takes a toll. Doing good very frequently involves hard work and risk. And to not acknowledge that in order to assist those who need our assistance, families, caregivers, professional, non-professional, facilities, really in fact have consequences. So part of the dilemma is that some of the cases in long-term care and continuing care have big discussions about when in fact an older person wants to remain in their own home, but the burden on their family is destroying the family. How do we begin? So that's how do we begin to balance some of these notions? And then health and social policy. I believe we need to really rethink the role of acute, fix-oriented health care and focus on the full continuum of health need. I know people who are now going into their fourth knee replacement. Please understand, I mean, I have one knee that I think may go on me. I understand the importance. But the fourth one? The point I'm making is we continually demand from the high technology side. And we have to understand that every one of those resources then is taken away from something else. And because we don't have this vision of our interdependence in the human family, we in fact don't see these aspects. Let's also recognize that the socioeconomic determinants of health, safe housing, good nutrition, those things for the elderly are often more important than an ICU in a hospital. It's the socioeconomic determinants that, in fact, matter day in and day out. And then my conclusion, I really think that we have become so focused on rampant individualism in Canadian, even in Canadian society. You can hear from my accent, I'm an American by birth, I am Canadian by adoption, so I am Canadian. And the values underlying the way Canadians used to think about each other in terms of healthcare and social services is in solidarity. We did take into account together supports. And I'm worried that right now, this competition, the old against the young, the old against the middle-aged, mitigates against working for a real new sense of what I call intergenerational justice. So respecting our elders, I believe we owe it to them. But respecting our elders in this day and age is not easy. Thanks.